بسم الله الرحمن الرحيم. إن شاء الله دلوقتي هنبتدي our session woman imaging. We will start with the دكتورة Heba Hassan, Alexandria University. She will talk about gynecological emergencies. اتفضلي يا دكتورة هبة.
Good evening, guys. I'm really excited. It's nice to be back on stage, not virtual anymore, though it had its privileges, just jumping out of bed. Just jumping out of bed 5 minutes before the presentation, putting your blazer on your jumper and slippers, and just smile for the camera. Unfortunately, you have a challenge. Try and jam. Unfortunately, you have a challenge to try and jam 12 hours of info in just 12 minutes. I don't know how we're going to do it, but bear with me, I think we're going to do it. Okay. Our aim here is to try and identify what are gynecological emergencies. The problem is you're going to have a female coming in with pelvic pain, and that's it. It can be gynecological or non-gynecological. And even the gynecological ones are a broad spectrum. Still, your job here is to try and identify the pathology as early as possible to try and deliver the best optimum management plan. The problem is that the juniors are the ones who are the first responders, and as we call them, and they always get panic, and I tell them, stop, take a deep breath, and focus. First of all, know what imaging modality you're going to use. The first and foremost line of imaging is still the ultrasound, and if you're dealing with a non-virgin female, endovaginal ultrasound is the king. CT and MRI are just used in certain settings, not in each and every case, especially that it's lengthy. And then you have to have a structured plan. What are you going to look for? First of all, if your female is in her fertile period, try to exclude emergencies related to pregnancy. Then the gynecological ones, and lastly, the non-gynecological ones. The idea is to put a roadmap. Even the gynecological ones are subdivided into adenexin that we're going to talk about, uterine, as well as miscellaneous. Let's start by the adenexin lesions. Okay, we have a cyst. What do you think this is? If we have one of the junior staff here, well, as you see here, we have what we call the reticular pattern in a lesion, and this is usually pathognomonic for a hemorrhagic cyst if it's more than 3 centimeters, or if it's less than 3 centimeters, we just call it a corpus luteum cyst. If you find it without any free-floating pelvic collection, then this is a reassuring sign. It's just pelvic pain, transient due to the distension by hemorrhage, and it's followed out by watchful waiting. But sometimes the cyst is not that clear, so you have to put other differentials. Another differential to the hemorrhagic cyst in setting of hemorrhage would be the endometrioma. You can easily differentiate between them by the history. Is it a once in a lifetime experience, or is it cyclic? Is it related to the ovulation, or is it related to the menses? And sometimes females do get acute abdominal pain for 1 or 2 hours at the time of ovulation, and when you do an ultrasound and you find nothing, even not a hemorrhagic cyst, this is what we call the Mittelschmerz disease, and this is a very self-limited disease, and you don't need to do something further. If your female is in her fertile years, you have to exclude ectopic pregnancy, because not all ectopic pregnancies would come with the classical sign of seeing the fetal pole inside the I don't know if it's okay, inside the cyst, and with an empty uterine cavity. And what's crucial is that you find it in what we call a para-ovarian location, because most of the ectopic pregnancies are tubal. And as you can see here, you cannot identify the fetal pole. It looks the same as a hemorrhagic cyst. Your clue here would be that is para-ovarian, and ask for a beta-STG, and not for urine, because it's notorious for being false negative. Ask for a quantitative blood serum beta-STG. And then we have the ruptured cyst. The ruptured cyst can be either the simple cyst, where you're going to have clear fluid collection, or it can be turbid, as in case of hemorrhagic or rupture of a hemorrhagic cyst, and here you're going to find turbid fluid, the same like within the cyst, as you can see here by CT. Your job here is to monitor these cases so that you exclude the cases of ovarian apoplexy. Ovarian apoplexy meaning that you're going to have a ruptured cyst with an active bleeder, and here you would put the patient on follow-up, and you'll find that the fluid would accumulate. Sometimes when you find that it's increasing, or even if your fellow clinician doesn't want to wait for the increase, you can do CT with contrast and look for active extravasation on the delayed images. If you find this cannot be managed conservatively. He has to go in by laparoscopy and ligate it. And then we have the setting of the dermoid cyst. The dermoid cyst per se is not an emergency, but its complications are. One of the complications would be a rupture of this cyst, whether due to trauma or iatrogenic, whatever the reason. And on ultrasound, you don't find that much vague details. It's non-specific, so you do a CT, and you can clearly pick up fat lobules lodged within the recesses. And since ruptured dermoid cyst would promote chemical peritonitis, you would find marked fat stranding and free fluid collection. And if you do a reformatting, you would find that the fat is actually floating upon the fluid as it's of a higher density. This is not an emergency. Lots of people might find during a CT scan the eggshell calcification surrounding a fat lobule, which represents an old episode of ruptured dermoid cyst, but this is not in the acute setting. This is usually coming for incidentally for another setting to do an CT, okay? And then we have the PID. The PID is usually a disease of exclusion. You would have, if you have the classical full-blown picture of fever, foully odorous discharge, the pain, and then you would find these cysts here. How would you differentiate it from a hemorrhagic cyst, and how would you differentiate this tubal distension from hematosalpinx? Just look at the wall. Of course, you're going to have the setting of the clinical scenario, but look at the wall. It's going to be thick, and if you open up Doppler, it's going to be hyperemic. And this is actually what we use when we do CT or MRI for these cases. You're going to have thick enhancing wall, whether of the tube or the cyst itself, okay? And this is PID. Sometimes your patient might come in not with pelvic pain, but with right hypochondrial pain, because she's going to be complicated by hepatic capsular inflammation that we term Fitzhugh-Curtis syndrome, okay? And then we have another entity, which is the ovarian torsion. It can either be a standalone torsion without any leading cause, or you might find a leading point. Usually, most commonly, it's a dermoid cyst, okay? The idea is, or your clue here would be having a sizable ovary with scarcely replaced follicles and marked edema. And if you are lucky to put both ovaries neighboring each other, you would find the discrepancy in the size, and you have the whirly appearance of the pedicle. And as you can see here, that we might pick up vascularity. Lots of you think that once we have an ovarian torsion, we should not find vascularity within the ovary. No, you can find vascularity. Usually it's of arterial flow, and this is either at the beginning of the torsion episode or at the end when there is torsion detorsion, and you can clearly differentiate both by the clinical. Once detorsion happens, the clinical pain would subside marvelously, okay? Sometimes it's a little bit difficult to identify if it's pure torsion or do I have an associated mass with it as a leading point. And here you do an MRI and not a CT. And as you see clearly here, this is just massive edema of the ovary. This is not a mass, this is just the ovarian edema itself. We don't do a CT for the setting of ovarian torsion because you don't sometimes clearly identify if it's just torsion or do you have a cyst with it. This case here was a 10-year-old female. She had right-sided pelvic pain, and she was suspected to be appendicitis. And when she underwent CT, we spotted that it's actually ovarian torsion, okay? Bear in mind that in the setting of pregnancy, the anatomy shifts. So don't rely on the notion that it has to be pelvic pain. No. Once the ovaries are high riding by the distended or increasingly sized uterus, the ovaries might shift up and you find your pain upwards, but still this is a case of torsion, okay? Another entity that's rare but sometimes can be spotted is what we call the isolated tubal torsion. You're going to find a twisted pedicle, but your clue here would be that you're going to have a normal sized ovary. The ovary would not be edematous and it would not increase in size. The problem is that sometimes it's a little bit difficult to identify by ultrasound. You would find only the whirly appearance and you do not identify the ovary that much. Okay, is it torsion ovary or not? Then you can do an MRI. It would clearly pick it up. And then we have the ovarian hyperstimulation. This has actually been seen nowadays more and more due to the assisted fertilization medication. It's very clear, it's a spot diagnosis. You're going to have both ovaries enlarged with multiple follicles. Once you see it, you have to split up the treatment because sometimes the cases might have an idiosyncrasy and they might even have to be admitted in the ICU. Now let's shift gear to the uterine lesions. They are less than the ovarian, but they are to be respected. The most notorious one would be the type 7, FIGO type 7, pedunculated subserosal fibroid with a long pedicle. It can twist, and it would lead to edema and even up to necrosis. The problem is that you do not know if the pain is just pelvic or pelvic-abdominal, and sometimes the pain shifts according to the position of the patient, where the fibroid itself might shift together. Okay?
Another emergency related to the fibroid itself would be what we call the red degeneration of the fibroid, meaning that there is massive hemorrhage, massive degenerative hemorrhage of the fibroid, not just spots like in the normal degeneration. You can easily spot it on an MRI by the single intensity of blood, as you can see. And this is usually spotted with cases of pregnancy due to the increased proliferation of the uterus in line outgrowing its blood supply. And as you can see here, we can easily spot it by the signal intensity. And as you see, it's away from the placenta, so this is not a placental hematoma. And then we have cases of spontaneous abortion without the first missed abortion. We're talking about the inevitable and incomplete abortion mainly. And here you find, having the severe reaction, you're finding the sac descending into the uterus, giving you what we call the figure of 8 uterine shape, filling up both uterine body and cervix, and you don't have any fetal pulsation in it, so this is abortion. And this is how you can easily discriminate from cervical ectopic, when you're going to have the sac only in the cervix, and you still find fetal cardiac pulsation. So this is ectopic pregnancy, this is not abortion. Even ectopic, when it distends the cervix, would lead to acute pelvic pain, which might be a case of emergency, of course. Another emergency related to pregnancy, but this time postpartum, would be the retained process of conception. The patient usually delivers normally, and then she will come in with persistent pain and bleeding. And you put the probe and you find the genital content within the uterus. You open up Doppler and you find vascularity. The fifth thing that comes in the mind of the junior staff would be that this is a trophoblastic tumor. No. Ask for beta ECG. If the beta ECG is high, then this is a trophoblastic tumor. If the beta ECG is nil or below normal, then this is just retained process of conception. So please put in mind that retained process of conception do attain vascularity events. Rectoplacental hematoma, again, depending on emergency, you're going to have pain. If it's just sealed behind the placenta, you find pain only. If it's in the marginal location, you can have pain and trickling of blood going through the vagina. Rectoplacental hematoma per se can be either life-threatening, a condition to the fetus, or not, according to the size. If it's taking less than the space of the less than 30% of the space of the placenta, then it can be managed by watchfully. A very maybe trivial finding, but still it does produce pelvic pain, would be the spaced IV. And here we are talking about the migrating or perforating ID. While it's going through the myometrium will contract vigorously as if in labor pains. Once it pierces into the abdominal cavity, the pain will subside. So if you find it inside the myometrium, you have to go in and take it out. Lastly, we're going to talk about ovarian vein thrombosis. Again, your clue here would be the clinical. You're going to have a patient, postpartum, coming in with low-grade fever, and she would give you this classical complaint of having a shooting linear pain along her flanks. If your patient is lean and you are lucky enough, you can see the thrombus by ultrasound, but we usually do perform a CT for such cases with cultures to identify the thrombus within the ovarian veins. So at the end, don't get confused, just put a roadmap, let's say a checklist for yourself. Are you dealing with an alexa lesion or a dry one? And carefully link it to your history. The history here plays a very crucial and